Of nursing care. 475, it will explain to you exactly what implementation phase of the nursing process is. So it is actually an evidence-based action that is planned and carried out by the nurse. Implementing these evidence-based practice actions help to achieve valued health outcomes. Important to know. Implementation is to help the patient achieve valued outcomes, as we mentioned on the previous slide, to promote health, prevent disease and illness, restore health, facilitate coping with altered functioning. Nursing implementation can be found on pages 475 to 478, and they include scope of practice, nursing interventions, taxonomy, structure, as well as care coordination and continuity. We will discuss these in further on the next slides coming up. The nursing scope of practice describes the services that a qualified health professional is deemed competent to perform and permitted to undertake according to their licensure. ANA describes the scope and standard of practice as the who, what, where, when, why, and how of nursing practice. So your scope of practice may vary slightly from state to state. Therefore, it is imperative that if you move to another state or are practicing in a different state, that you are familiar with the scope of practice for that particular state for your licensure. Nursing interventions, taxonomy, structure. So nursing intervention classifications, or NIC, is a research-based list of nursing interventions that has a label and a definition and a set of activities that nurses perform to carry it out with a short list of background reading. So this is evidence-based practice. So the researchers of NIC are also dedicated to developing nursing outcome classifications, or NOC, for these nursing interventions. The aim for this NOC research is to identify, labeling, validate, classify nurse sensitivity, patient outcomes, and interventions, evaluate and validate the usefulness of the classifications of the clinical testing, identify test measures, and the outcomes and indicators. Our final focus, the care coordination and continuity that the nurse provides. So care and coordination and continuity becomes the nurse's responsibility. The nurse reads, consults, makes rounds with the disciplinary team. She also communicates and collaborates with other team members and specialists to ensure the continuity of care for her patient. Critical thinking, clinical reasoning, and judgment and implementation. So on page 478, there are several bullets that talk about the process: assess, reassess, revise, record. So you're going to assess the patient before implementing any nursing actions or interventions. You will reassess them to determine their response to the nursing action or intervention that was implemented. You will revise the approach if in fact it is appropriate. So if in fact the results did not yield what you were expecting, then you would make a revision. However, you always want to record your patient's response, whether it was effective or ineffective, or the plan of care is continuing, and any modifications you made to that plan of care, if in fact that was needed. Types of nursing interventions, page 479 to 480. So we have direct and indirect care. So direct care are interventions or treatments performed through interaction with the patient. And indirect care are interventions of treatments performed away from the patient, but on the behalf of the patient, such as consulting a specialist or collaborating with a care team on the behalf of your patient. Next, we have independent and collaborative interventions, and they are demonstrated when you implement the care plan intervention. So this is nurse-initiated interventions, such as repositioning your patient in bed. Types of nursing interventions continued, page 479 to 480. Protocols and standing orders. So protocols are practices that are clearly defined for specific situations. Some protocols have standing orders that allow the nurse to initiate action that usually will require an order. So some examples of protocols. On admission, you may have in some facilities a protocol that the patient is not to be ambulated, even to the bathroom, until they have been evaluated by rehab. So that may be a standing protocol. You may also have some standing orders. So protocols that have standing orders, such as an order that allows the nurse to initiate action. So DC a Foley on admission if they do not have a diagnosis that warrants a Foley, such as multiple stage 2s or stage 3 or 4 wound, urinary retention, neurogenic bladder. If they don't have certain diagnoses, then a nurse must DC that Foley catheter and monitor their urine output for whatever time that policy says. It may just be for that first shift. It may be for the first 24 hours, and it may include bladder scans and recording of the amount. Okay, so that's one example. Another example of a protocol that has standing orders could possibly be bowel regimen. If your patient does not have a BM in 3 days, then they are to have milk of magnesia. Then they'll progress to a suppository, then an enema, or if they're on narcotics, they may have a bowel regimen. Their standing orders for Tylenol for pain, mild to moderate pain, or Tylenol for fever. If it's above a certain degree, then they will receive Tylenol for fever. So these are examples of protocols with standing orders. Okay, so this picture is found on page 478, and it explains implementing, which is carrying out the plan, continuing data collection, and modify the plan of care as needed, and document the care. Okay, so these are all key factors in implementing the plan of care, okay, or implementing the interventions or nursing actions. And then these arrows are showing nursing variables that influence or that impact the nursing implementation of care. So on page 488 to 490, it talks about each of these nursing variables in further detail. So implementation of care is influenced by nursing variables such as the nurse's scope and standard of practice, research findings, ethical and legal issues, resources, and the nurse's knowledge and use of nursing measures. So every nurse does not have the same experience, does not have the same specialty, does not have the same knowledge. So with that said, depending upon the nurse that you have, the experience, her knowledge base, and her specialty, you may have someone that's more creative and able to think of innovative ways or more interventions to benefit the patient health versus another nurse. Implementing the plan of care, pages 480 to 485. So determine what the patient need or their continued need for assistance. Promote self-care, so you want to encourage the patient to do as much as they can for themselves. Assist the patient to achieve valued health outcomes. Reassess the patient and review the plan of care. Use the whiteboard. So there's a board, and usually in acute care, and the providers and the team members that's caring for this patient name is on there, whether the patient's in any pain, their primary contact or responsible party information is on there, and anything that's pertinent for that patient's care, the patient's goals. And I believe in your book, they do have a sample of that on page 481, how much assistance they require. Oftentimes their diet is there. So use the whiteboard, because therefore anyone of the care team members can walk in, read the whiteboard, and everyone will have the same goal, have the same picture of the client, and better outcomes will occur. Plan ahead and organize resources. Clarify prerequisites for nursing competencies. Anticipate unexpected outcomes and solutions. Ensure quality and patient safety. Promote self-care, teaching, counseling, and advocacy. Assist patients to meet health outcomes. I mentioned that early on. Okay, implementation of guidelines. So this is on page 487, box 18-1. And this goes over 2 slides. So the family and patient is always supposed to be a partnership in their care. So you do not want to just dictate nursing actions and nursing care and nursing care plans. However, you want to get the patient and their family to buy into the care plan. Before implementing any nursing intervention, you want to assess the patient and reassess the patient to determine whether the action was still needed after the initial implementation. Approach the patient competently. You want to approach the patient in a caring manner. Modify interventions as needed, so according to the patient's developmental and psychosocial background, ability, and willing to participate in the care plan, and their response to previous nursing interventions, and their progress towards their goal or outcome. Implementing guidelines continued, so make sure that your nursing interventions are best standard practice and are legal and ethical. Always question that the interventions selected are the best possible alternatives for your patient. Develop a repertoire of nursing skills, of interventions that can be used for your patient to have a greater or better outcome. Delegation is the transfer of tasks performed while retaining their accountability for the outcome. So ultimately, you are still responsible for that patient or that task. On page 491, box 18-2, it explains each of these rights in detail. So these are the 5 rights of delegation. So you must make sure that you are delegating the right tasks to the right individuals. They are qualified to perform the tasks in which you are giving them. It's under the right circumstances, so they're stable, unstable. You want to make sure it is the correct circumstances and everyone's safe. You are delegating the right to the right person, right? So the right person could be their actual skill set, right? So a new grad who does not have experience with a blood transfusion, even though she's an RN and according to law, she's able to perform a blood transfusion, but her inexperience and her lack of knowledge does not make her the right person. the right direction and communication. So you want to speak clearly and concisely and make sure that the person you're delegating to knows exactly what you are expecting of them. And the right supervision and evaluation. Because you delegated the task does not mean that you do not need to follow up. Actually, it is essential that you follow up and make sure that the task was completed in its entirety accurately and safely. And then evaluate if, in fact, the task was effective or not, especially as the RN if you're delegating to an LPN or a CNA. That evaluation piece is essential because you are the person that is able to do the assessment and to really determine the needs of your patient. Refusal of care, page 490. So if a patient is refusing care, the nurse's first responsibility is to identify why they are refusing care. So you want to have dialogue with the patient. You want to meet the patient where they are. You want to understand what they're thinking. Why are they refusing this medication? Why are they refusing this bath or refusing to walk or refusing therapy? So you want to make sure you understand why they are refusing care, right? Find out what's important to them. And then you're building trust, and they will more likely listen to you as far as understanding the reasons why this particular nursing intervention, or even if it's not nursing, it could be rehab or it could be a blood draw, a lab, right? Is important. So common reasons for noncompliance is found on page 490. They include a lack of family support, lack of understanding about the benefits of that particular therapy or treatment, low value attached to the outcome, adverse physical or emotional effects of the treatment. So I know someone that was supposed to have chemotherapy, chemotherapy for cancer, and they were really concerned about losing all of their hair. That was very important to them. And if in fact they had to lose their hair, they really did not want to have that therapy, that particular treatment. Inability to afford treatment, limited access to treatment. So all these are reasons for noncompliance or refusal of care. I do want to mention that noncompliance is a term that we frown upon as healthcare providers or healthcare professionals. So the patient has the right to refuse care. So noncompliance indicates that they are they don't have that right to refuse care, right? If they're a sound mind, they are able to refuse care. So we really should say care refusal of care opposed to noncompliance. On page 491, box 18-2, it lists a checklist for organizing student clinical responsibilities. So during your clinicals, you should have received this information from either your clinical instructor, nurse, nursing aide, or other collaborative team members, such as the treatment nurse or nurse manager, right? Possibly therapy, depending upon where you were at, or a specialist. So your patient's name and profile should have been given to you. If you were in acute care setting, their chief complaint or reason for admission should have been given to you, or you should have received that in a report from your nurse. The current health status, you should have received a report from your nurse. So long-term care patients, because that's their home, a lot of these acute things do not, you would not have received as far as a chief complaint or even current health status, because we're in their home. Routine assistance needed. You should have received that from the nurse or the tech, or if you were in the long-term care area, the CNA, nurse or nurse manager. or even your clinical instructor. Priorities for nursing care and any special events for that day. So some of you guys in long-term care may have had patients that needed to go to or desired to go to activities at a certain time or play bingo at a certain time, or they may have rehab scheduled, or possibly just, lunch, breakfast, those things are scheduled as well. Special teaching, counseling, or advocacy. So, especially for our acute care students, you may have been involved in discharge teaching for your patient, or maybe even diabetic teaching for your patient, or wound care teaching, or some type of teaching related to a new diagnosis or new medication, which I hope that you guys experienced. That would have been great. Um, or maybe even communicating with another team member, such as a physician assistant or physician or nurse practitioner overseeing the care of your patient, and any special family needs. So occasionally you'll have family members that will come in and they may desire certain information, or they may desire to watch their loved one during their rehab session to see how they're progressing in preparation for discharge, or they may desire training, wound care training, or teaching about how to administer insulin to the new diabetic that they will be caring for at home. Okay, so we have a question. Which of the following nursing interventions is an indirect care intervention? So a nurse explains available birth control measures to a young couple. B, a nurse meets with a collaborative care team to plan nursing measures for a patient. C, a nurse prays with a patient prior to surgery. D, a nurse administers pain medication to a patient with end-stage renal cancer. All right, so let's think about what indirect care intervention is. So indirect care intervention is something the nurse is doing on the behalf of the patient, but it is not at in front of the patient. It's not caring directly caring for the patient. So it's away from the patient that the nurse is performing this, but it's on the behalf of the patient. So the nurse explains birth control. The nurse is with the patient, so we can eliminate A. The nurse meets with the collaborative team. Sounds like she's away from the patient. Possibility. C. The nurse prays for the patient prior to surgery. Sounds like she's with the patient directly, so we can eliminate C. A nurse administers pain medications. She's with the patient directly again, so we can eliminate D. Therefore, our answer is B. The nurse meets with a collaborative team to plan nursing measures for a patient. And here is our answer, and it is B. An indirect intervention is treatment performed away from the patient, but on the patient's behalf or group of patients, such as the example that B has given us, consulting a collaborative team. Which example illustrates a nurse variable influencing patient outcomes? Okay, so now you have to remember the nurse variables that we spoke about in lecture. However, if you do not recall them, then you can try to use some of your test-taking strategy skills. So a nurse variable that influences the patient's outcome. All right. So nurse variables influence the care plan, and there are several things that we mentioned in our lecture. So, however, we look at our options. A patient in a nursing home refuses to take their medication. That is not a nurse variable. That is a patient variable because the patient is making the decision, right? A low-income family is unable to afford formula. for their newborn infant. That is not a nurse variable. So this is not a nurse causing this food insecurity for the infant, but this is a caregiver's variable or a patient variable, right? An alcoholic patient is unwilling to participate in the AA meeting. So this again is a patient variable. The nurse is not involved in that situation. This is the patient making a decision to refuse AA meetings. Now, if you look at A and C, they both are refusals. So these two answers likely will be canceled out immediately anyway from our test taking strategies because we have a refusal and a refusal, and we know there's only one right answer. So even if we did not realize they were patient variables, we can then say they are both refusing, we're eliminating them, we're stuck with these two answers, B and D, and then we can choose from the best, and we have a 50-50 chance of choosing the correct answer. So for D, a rape victim does not receive counseling in the emergency department because a counselor is not available. So this is not a patient variable. The patient is able and willing to participate in counseling in the emergency department. However, because we are short-staffed, and one of the roles of a nurse is a counselor, so don't take counselor as that's a psychologist or a therapist. This could be a nurse that is trained to deal with rape victims, and therefore, because they are not properly staffed, this variable is affecting the patient's plan of care. So in our lecture, we talked about nurse variables and the influence on the care plan. So they include resources, and in this example, D is a resource problem. We don't have the proper staffing. Current standards of care, right, or their scope of practice. Research findings, ethical and legal issues or guidelines to practice, as well as incorporating nursing measures or indicators that goes along with the patient's experience, specialty, and knowledge. So our answer is D. A rape victim does not receive counseling in the emergency room because a counselor is not available. I spent a lot of time on that particular slide because I know someone in the class had a question about it. All right, question. When a patient fails to cooperate with the care plan, despite the nurse's best efforts, it is time to reassign the patient to another caregiver or caretaker. True or false? Give you a second. And the answer is false. When a patient fails to cooperate with the plan of care despite the nurse's best efforts, it is time to reassess the strategy, right? So you want to find out why they're refusing care and try to meet them where they are. Make sure they understand, have full understanding of the reason this care is necessary, and in fact they are making a well-informed decision, then it is our job to then document and advocate for that patient, whether it is a good decision or a poor decision.